So do anticipate that. And if you require translation, we have translators, I believe, into French. Yeah. French translation, if you need, please access at the back and you'll be given the device so you can listen in your preferred language, French, or just listen in English. All right, so with that, we have our speakers ready. But before they join us on stage, we're going to watch a short video. And this video is on innovation for leishmaniasis in East Africa. So let's roll.
My name is Luke Kanyangare. I once contracted leishmaniasis in 1989. I was 15 years old, trying to study hard so that I can pass my exam. But unfortunately, I fell sick.
Leishmaniasis is a disease. It's mainly a disease of children. It's caused by a bite of a female sandfly. The school-going children, out in the dark, they will still be playing their football or sit outside, and then boom, they bite you. Once this fly bites this person will get very sick. Diagnosis is very difficult. Without treatment, this person infected with leishmaniasis will surely die.
I was unwell, the fever is too much, the headache is too much, there's pain all over. All the other tests were negative, malaria negative, everything else was tested negative. I continued with the same sickness until around January. That is when I was supposed to join from secondary school like my colleagues did. My mother took me to another hospital again. After 3 days, the results were out, leishmaniasis positive. I was started on treatment. And the treatment now was, it was another hell.
We didn't have a treatment that was safe. The treatments that we were using were themselves toxic. But because there was no other option, I had to give these treatments.
When I got the first injection, I thought this is now the real death. They told me that this treatment is going to take 30 days. On the 5th day, I was brought to Kachelinga to continue with the 25 injections which were remaining by then. My mom dedicated all her time and forgot all the other children at home and stayed with me all the time in the hospital. I continued with the same painful injections until I finished my injections in March.
Leishmaniasis is a neglected disease because really it affects the poorest of the poor. When we started working on them 20 years ago, the pharmaceutical industry is not interested because they are too poor to buy the medicines that will be produced, so why make medicines for them? In the 90s, the frustration of those doctors in the field, not knowing what to do with this disease that seemed to be affecting many people, but they didn't have the treatment for it. When we started in 2003, we quickly embraced everyone who was working with leishmaniasis. Come, let's work together. Let's find out from the patients what is best for them. At that point is when we established Leishmaniasis East Africa platform. Because of the work that Drug for Neglected Diseases Initiative together with our partners, there are now treatments, options that are available. The patients with leishmaniasis suffer in silence, but then you get someone like Luke, who's been treated, and now he has his voice, and he's a voice for the others.
I finally ended up being the nursing officer in charge of the same facility where my life was saved. One thing that is showing me that there is some light at the end of the tunnel is the kind of research that is being conducted right now, courtesy of DNDi at my facility. We are really working hard to achieve oral treatment.
The future is bright. DNDi is working very hard together with partners to try to bring new treatments that would really make a difference and be a game changer. We'll be able to treat many people and treat them at home. We'll cut the cost of transport, hospital stay, and also the duration of treatment.
So I encourage them that though the treatment they are going through is very painful, there is hope in the near future we may have a better treatment.
And so we are in the cusp of something big.
My experience with leishmaniasis, it taught me to offer my life for others because others also offered their lives for me. I dreamt for a better treatment of leishmaniasis. It has been 32 years and my dream is about to come true.
Well, I think a round of applause is in order. This definitely feels like a movie premiere with voiceovers by Monica. But no, really, really inspiring short film there. And now we're about to listen to some finer details to this story and also other stories on similar diseases. I mean, think about it. How quickly as a world we're able to rally to find a solution to COVID, and yet diseases like leishmaniasis, human African trypanosomiasis, Chagas disease, others have been with us for so long, and we are only just about getting a handle on them. Indeed, as the voice of Monique Wasuna said, we are on the cusp of something big, and it's really exciting that this is happening at this time. With that, I'd like to invite our first set of speakers. There's 3 of them. I would call them rapidly to the platform to sit, and then I'll introduce them one after the other. So the first is Dr. Natalie Stroop-Wograft. The next is Dr. Tony Ukati. And the third is Dr. Sar Bakhait. A round of applause for them, please. We're going to kickstart the first presentation, and Natalie is going to speak to us about COVID-19 response and pandemic. Well, she is the COVID-19 response and pandemic preparedness director at DNDi. That sounded a bit fun. I was like, well, that's not exactly what she's talking about. Well, so she has been with DNDi since 2009, and she's a member of the global executive team as the COVID-19 preparedness director, having over 30 years of experience in R&D for the past 12 years. I could go on, but perhaps more recently what she's been engaged in is as the coordinator of the Anti-Cough Study Consortium and one of the initiators of COVID-19 Clinical Research Coalition, this large coalition. She's also one of those who have set up a new pandemic preparedness platform for health and emerging infectious response, otherwise known as Panther. So Natalie is going to speak to us now on sleeping sickness, a treatment success story through partnerships and innovation in Africa. Natalie.
Thank you very much, John. And I'm so happy to speak about NTDs again, because yes, I've moved to other areas, but it's so nice to be able to share a bit what has been quite a passion for me for the last 13 years. And talking about sleeping sickness will be, in fact, a nice continuation from what Monique in the video has been talking about. I think NTDs do share the same characteristics of stigma, of abandon, of not enough research, and of not-profit, meaning that there's something that we have to be very careful that we keep the interest on NTDs, as maybe there are more. There's pressure on other situations. So maybe just to, this is a picture of the one of the National Sleeping Sickness Control Program unit in the DRC. And just to mention why DNDi was founded, exactly the same as what Monique has mentioned. Same problem of also MSF doctors in the field treating patients, and 1 out of 20 of those patients that they were treating, they were also seeing them dying from the treatment. So you can imagine how frustrating, difficult, terrifying this was for them. And that led, with others, in the building and of DNDi. So now speaking mainly of sleeping sickness, so again, as leishmaniasis, this is a disease that, if it is not treated, will lead to the death of patients. It is transmitted by the tsetse fly. It is quite difficult and burdensome to diagnose. It can affect many, many, many countries, even if we are in a very good situation now where there are much low caseload, because as you can see in 2020, there were less than 1,000 patients reported, possibly underdiagnosed due to the COVID pressure, but still lower cases due to the progress of new treatments. So, just to bring you back to where we were with when we started, sleeping sickness occurs in 2 stages of the disease, and when we started, there was a need to understand what those stages were, because the treatment was not the same for the first and the second stage. Second stage is the stage that gives a name to the disease, where patients fall into sleepiness, which means, in fact, coma and death. But when they are at this stage of the disease, and all patients will progress from stage 1 to stage 2, whatever, if you don't treat, well, you need to make perform a lumbar puncture. You can see the lumbar puncture. We all know what a lumbar puncture is. It is so painful. There's a lot of headaches post-lumbar puncture, but it hurts. And because it hurts, one of the patients don't want to be tested. They don't want to go for diagnosis. Why would they? When they have mild symptoms, they are not yet at this stage. So it is very important that we find a treatment that doesn't require a lumbar puncture. So we developed a TPP, a target product profile, in 2009, 2010, and that TPP laid out the grounds of what DNDi was mandated to develop: an oral, stage-independent, safe and effective field-adapted treatments. Simon will speak about access and the field issues. That is central, but we had, I think, this in mind. This talk is about partnerships. So the way DNDi has been working, as you heard about the LEAP platform, for sleeping sickness, DNDi coordinated a platform of partners, like-minded, who are, in fact, all the stakeholders that have a role to play in the treatment or the management of patients with sleeping sickness, or the policy and adoption of any program that would come from the DNDi, from the research. So many, many partners that are listed here, but what is central is to remember that the National Sleeping Sickness Control Program has been our main partner in conducting all the research. So what are our objectives? Our objectives are to deliver breakthrough treatments and expediting access to sustain elimination. The other Kigali event was about the NTD roadmap, which took place in June, where the NTD director, Mwele Malesela, has with partners identified that for 2030, in relation with these, the SDGs, should be part of those diseases that have sustained elimination. So the challenges of treatment that were existing was, the first one we had when we started was melarsoprol, that terrifying treatment, extremely effective, but also killing some of the patients due to its toxicity. So what we did was to develop fexinidazole. I'll speak to this in a minute. But before we engaged in the research for fexinidazole, but we also tried to have a more pragmatic response by combining an intravenous treatment, eflornithine, with an oral treatment, nifurtimox, which was endorsed by the WHO added to the essential medicines list in 2009. Then we continued, and now we have a much more ambitious goal with a new treatment that is called acoziborole. I'll speak to this in a minute. So just, I'm not going to be long, but maybe because it's important that we understand the challenges that DNDi faces in all of the diseases we work in. We have some infrastructure challenges in combating robust clinical research, and we want to insist here that the partners that have been conducted the work on fexinidazole and acoziborole have really done the best science. We say the best science for the most neglected, but this is what they did. You can see the challenges. Patients are living in rural areas. Usually the fly likes, the rainy forest and where there are rivers. It doesn't fly much, it's quite lazy, but the patients are very far. It's very far and in the very central regions of the DRC or other regions. So the thing is that when DNDi conducts its research, it goes where the patients are. It's not the patients that come to centers. That's critical. But to find those patients, you can imagine how logistically, even to get to the villages where they are, it's challenging. When we started, the wards were not so equipped. The infrastructure sometimes was okay, but most of the time not okay. The labs were, you can see here, not in the best conditions. They didn't have a lot of tools. They didn't have biochemistry. They didn't do ECGs in those remote areas. This was in 2010. I believe things have changed, but I have to tell the story. And so we managed to use, for example, helping to find patients through mobile teams or moto mobile teams. We equipped the wards, and I think we can mention for Kimalel also some infrastructure support that was done. We brought internet. How can you do solid research without having access to the data, making sure that patient safety is okay? We brought power. We did waste management. We equipped the labs. So all of this was done. So you can see here a slide where you show this, the labs. Now, other challenges that, this is just one slide, and I think we would need probably 2 hours or more to discuss this. I'm just posing this here. One is patients' vulnerability. In fact, access to research is access to treatment. So how do you make it, quite fair that they have the choice of not entering into research, but also they do understand what the research is about in the conditions where, for example, they are not very literate. So one of the things we did, and many are doing that, is to develop some visual tools to make sure that it was clear, especially the expected side effects of the drug. So I think you can see someone vomiting and another lady holding her head. That's to explain the side effect. But if you don't have, we've learned this, and everybody's talking about this on COVID, if you don't have community understanding, buy-in, and engagement, you will fail, whatever. So that was part. The other one which is critical is I'm done. The other one which is critical is the human resources at the site level, because as we said, we conducted the research where patients were coming, and at that time, there was not enough expertise in research, not enough access to training. So we did immense training. A lot of people were trained on clinical trials, on GCP, on lab, on conducting an ECG, looking at lab results, many things, doing resuscitation. But also we had a nice program of peer-to-peer, so PIs coming to train other PIs from site to site. That was quite nice. So our objective is to get a simple test and treatment strategy that will work in the context. For fexinidazole, we've made huge progress. It's been registered. It's now registered in the DRC, Uganda, and the FDA. With the platform, we are conducting a lot of access activities with a lot of people trained. We're doing training for pharmacovigilance via the training that we're doing for fexinidazole access. And we have also a very positive results on fexinidazole in TB rhodesiense. TB rhodesiense is the most fast-killing version of a sleeping sickness. So that's quite encouraging. And the next one is our new product, which is called acoziborole, very revolutionary. So someone is playing with my slides, but I will still speak on acoziborole. That's done on purpose. Sorry, now it's not working. Okay, so we just published the results on acoziborole. So acoziborole is really a dream because it's given once a day. No, 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 never mind. It's given once a day, and it has the same efficacy as NECT, a combination of infusions and oral treatment. It has a 95% efficacy in the most stringent analysis. This is unbelievable. This is fantastic. This is the work of many, many. And we hope that acoziborole will become a tool that can be used in all patients without the lumbar puncture, and maybe also what we're testing now in zero suspects. So not even people who have been diagnosed with the parasite, where you can identify the parasite in the microscope, but maybe also just based on a suspicion via RDT. That would be absolutely fantastic. So my last slide is that there is indeed now strong hope that one of those diseases, and there are so many, we'll speak to that later, one of those diseases could become a disease for which we can reach sustained elimination of transmission. And my last comment was to say that this could not and cannot be done without solid, trusted, clear, creative, and sustained partnerships, including with our partners from the industry, which I haven't mentioned. That's it for me. Thank you.
Wonderful. Thank you very much, Natalie, for that really inspiring presentation on HAT and the progress that has been made so far, and this new, acoziborole. I hope I got the pronunciation right. Indeed. I think it's really exciting times that we live in, and we'll soon come to the questions for you. But I want to go on to Dr. Tony Uketi, and Tony is going to speak on current advancements and the remaining gaps in onchocerciasis elimination. As you know, onco is one of the 5 PC NTDs, preventive chemotherapy NTDs, which have been earmarked for elimination. And we've made a lot of progress globally, but there are still gaps remaining. For over 3 decades, Tony has been a leader in public health ophthalmology and specifically NTDs worldwide. He practiced public health ophthalmology in the DRC for 16 years, and then he served as the coordinator of the Onco Control Elimination Program in both the Prevention of Blindness and Deafness Unit and the Department of NTDs at the WHO. So he's published extensively, and particularly was involved in publishing the WHO guidelines for verifying the elimination of onco. He's worked with ministries of health in Chad, in the DRC, South Sudan, Uganda, and specifically via their onco elimination committees. So, Tony, the floor is yours. Thank you.
Thank you very much, Mr. Chair, for this nice presentation. I think this is the first time for me to attend a meeting where I really don't know a lot of people. It's unusual. And number 2, I'm going to talk to you about onchocerciasis. And onchocerciasis, we have very few ophthalmologists and very few people involved in onchocerciasis. I hope at the end of my talk, I will convince you about onchocerciasis. Onchocerciasis, or river blindness, is one of the diseases targeted for elimination by WHO. It is estimated. It is endemic in 31 countries in sub-Saharan Africa, and this represents about 99% of the disease globally. Recently, the global burden of disease study suggested more than 1 million DALIs were lost due to onchocerciasis, and this is mainly associated with a decrease in productivity. Now, what the international community has done so far in order to address the burden of onchocerciasis. As you can see on the slides, we have 2 main programs and 1 project, which was set up by the international community in order to address the burden of onchocerciasis. The first one, which was launched in 1974, it took almost 28 years to be implemented. This is the onchocerciasis control program, and it involved 11 countries in West Africa, using mainly vector control. And why? Because a lot of people were blind in West Africa, particularly in countries such as Ghana, Burkina Faso. And the second one is the African Program for Onchocerciasis Control, EPOC, which was launched in 1995. And it took 20 years to be implemented. And the strategy was mainly using the mass drug administration of ivermectin. And that drug really did a lot of good things, and mainly those who had skin diseases were relieved, and the disease was controlled a lot in a lot of areas. And the third one was launched in 2016 by WHO, called ESPEN, and this one actually was the packaging of the strategy by giving ivermectin with other drugs in order to control or to eliminate NTDs. And in 2021, WHO set up, developed a new NTD roadmap with very clear targets. And those targets were set up in order to help us to reach almost the year 2030 with a very good result. With regard to onchocerciasis, we have three main targets. Number one, to eliminate the need of ivermectin MDA in at least one focus within those 34 countries. Number two, to eliminate the need of ivermectin MDA in more than 50% of population in at least 12 countries out of those 31 endemic countries in Africa. And the last one, the third one, is to eliminate the need of ivermectin MDA in entire country. Those people who are at risk of getting the disease in at least 12 countries. As you can see, these targets are very challenging, and hopefully by the year 2030, we will be able to reach at least some of them. And we do have challenges in order to meet those targets. I've just listed 6 of them here. Number one, the mapping of the transmission zone. The challenge we are having today is the tool we are using in order to map the disease. Why? Because the tool can only determine the historical status of the disease. And in our case, we would like to have a tool which can help us to determine the active transmission of the disease. Unfortunately, so far, we don't have it. The second challenge is the coendemicity between onchocerciasis and loasis. Today, we have 10 countries in Africa, mainly Central Africa, and particularly in Cameroon and DRC, where we do have challenges of meeting the geographical and therapeutical coverage of our intervention. And the third challenge is the cross-border issues. WHO guideline requires us to be sure that there is no risk of getting the disease in the country coming from the other country. That's why cross-border issues are challenging, and in order to put countries together, we would really want WHO to take the lead in order to organize the meetings between countries. Number 4, diagnostic tools. Right now, we do have challenges in mapping the disease, especially the transmission zone, as now we have reached the elimination stage of the disease, excuse me. And also when to stop the treatment, the MDA. Number 5, we do have areas where we are still treating for more than 15 years. There must be some reason. Maybe insensitivity to the drug, ivermectin. Therefore, there is a need to develop alternative interventions tools. I will come back to that. And number 6, I think those who used to be during OCP era, they know that entomology was well developed. And these days, entomology has been left behind, and there is a need to have entomologists in order to help us to determine the breeding sites, to also come up with the tools which can be used by the countries. And as I said, let us see in more details the alternative intervention tools we have so far. For the vector control, there are some fly traps which can be used in order to capture, instead of using human to capture the flies. We have another strategy called slash and clear, which can also limit the risk of the insects. And with regard to the drugs used, today we have moxidectin, which is currently developed by MDGH, an Australian NGO. And myself, I'm currently involved in trials in testing moxidectin. We have exposed more than 5,000 people under this treatment, which is targeting mainly onchocerciasis, probably lymphatic filariasis, and STH. And DNDi is also involved in developing some of the molecules for onchocerciasis, namely flubendtylosine. I think that's it. And I think it is also effective towards lymphatic filariasis, hemodepside, specifically for onco, and oxfendazole, onco, LF, STH, and loasis. In conclusion, we do have tools. Onco is there, has been there since more than 50 years. WHO has the new roadmap. Let us join hands together in order to address these challenges so that we can meet the target of 2030. Thank you very much for listening.
Thank you very much, Dr. Uketi, for that insightful presentation on where we are with ONCO, actually how far we've come and where we are. That was a lot packed into 10 minutes, and I've already learned a lot, especially the prospects that we have for new medications. There will be questions for you soon, but I'll go to the third presenter, and she is Dr. Sahar Bakhait, and she's going to be speaking on mycetoma and the need for innovation for this highly neglected disease. She's from the Mycetoma Research Center in Sudan, and she is currently the head of the Department of Molecular Biology at the Institute of Endemic Diseases, and also she's a research coordinator for mycetoma at the University of Khartoum. She's been involved in investigating this disease, particularly around the genetic susceptibility and biomarkers, diagnostics, and immunity. And she was among those who worked on the first clinical trial on a new treatment for mycetoma that was funded by DNDi. She's also very big on capacity building and training the next generation of scientists. Dr. Sahar Mubarak Bakhait, we look forward to your presentation.
Thank you. Good evening, everyone. It's a pleasure to be part of this panel. And I would like to thank DNDi and Dr. Monique Wasuna for giving me such an opportunity to participate in this event. So I'm talking today about mycetoma, and I'm going to share some of my experience in the last 10 years working with mycetoma and mycetoma patients. And the topic is really big, but I'm going to highlight some of the main important things in innovation in mycetoma that we need to discuss it in this meeting. So my talk will be about mycetoma, the need for innovation for a highly neglected tropical disease. I'm talking about mycetoma globally, but also I'm coming from Sudan, and mycetoma is endemic in my country, affecting young people and causing a lot of disability and social problem. So for those who don't know about mycetoma, mycetoma is a granulomatous disease caused by a substantial number of microorganisms, fungal or bacterial. It's a chronic disabling disease characterized by massive deformities and destruction leading to a loss of function. Mycetoma was neglected for a long time. It was added to the WHO list of neglected tropical disease in 2016, and since then the attention is coming to the mycetoma and to the mycetoma patient. Mycetoma affecting the poorest of the poor patients. They are coming from low socioeconomic background, and they don't have any access to health care or to the medical services in these endemic areas. Mycetoma are two types, bacterial and fungal. The bacterial type of mycetoma is caused by actinomycetoma, and the fungal type is caused by eomycetoma. And up to date, we have more than 70 species causing mycetoma. And for the last 2 years, we have isolated 11 new species that cause mycetoma in the endemic area. And this is one of the main issues and the problem in diagnosis this disease. The impact of mycetoma is really big because it causes disability. Most of these patients, they come late for medical treatment, and the final end point is amputation of the legs or the hand or any affected part of the body, and this affects their life. They become dependent, and they have a lot of social problems, stigma, and etc. Mycetoma is distributed globally in what is known as the mycetoma belt. And as you see, my country, Sudan, is highly endemic in this disease. And also, as we are working at the Mycetoma Research Center to help patients in our country, still the disease is neglected, and those patients are really neglected. So from my experience working with the mycetoma in Sudan, I have identified some gaps in the knowledge about the disease, and there is an urgent need for innovation in such areas. The surveillance, the treatment, the diagnosis, and the rehabilitation care for those patients. In the surveillance, of course, we need an innovative surveillance tools, working with epidemiology of the disease, solving the gap of the knowledge in the epidemiology of mycetoma, not only in Sudan, but globally. We need the new or improved drugs for mycetoma, and maybe we should think about doing immunotherapy for those patients. And for the diagnostic, which is a big problem, we need a point of care test for this disease. And most of these patients, they need new care model for comprehensive rehabilitation. I have to say, the most affected age groups are from 20 to 40 years old by mycetoma. The innovation process is a very long process, but at least we are happy that we are moving. With the help of the different partners working with mycetoma, we are doing some discovery, drug discovery, development, validation, and I hope maybe in the next 10 years, we will reach that point of implementation and evaluation of the different innovation process. So talking about epidemiology of mycetoma, and we need to promote the innovation of mycetoma because there is a huge gap of knowledge globally, not only in Sudan. We started using the surveillance tools by house-to-house surveys using a paper of questionnaire. Now we develop this kind of tools, computer tools. It's called CAPI. It's a computer-assisted patient identifier. Through this program, you can just download it in your mobile or on your computer or your tab, and then you can trace the patients in the endemic areas, take the coordinates of the patient, take photos, write all the medical history, and all this data will be directly connected to a server where it can analyze all this data. We are trying to validate this method, and maybe in the future this can be adopted in other countries globally, in the other countries endemic in mycetoma. One of the, I think one of the very important things that we did in the MRC, we have what we call the model, environmental needs model techniques. We have collected all the data of mycetoma patients and the environmental data, and we created a model that can predict the disease in different areas in the country and can even identify the hot areas like here, you can see in Sudan, it was clearly identified that there are 3 main states are highly endemic in the disease, and I think we need to work on such kind of model to be more innovative in the surveillance of mycetoma. Treatment is a very big problem in Sudan, and it's a generally combination of medicine and surgical, and the EU mycetoma or the fungal type is the most difficult type, and usually it is a combination of antifungal therapy with surgery. That's why we need more innovation in the mycetoma treatment. And so far, what has done in this? We had the first ever clinical trial in mycetoma funded by DNDi using a prodrug called phosphoroconazole. This is a prodrug rapidly converted to rofuconazole, and this drug is taken once a week and is cheaper than the standard drug that used to treat this type of. I think we need now more clinical trials in mycetoma and more maybe thinking about immunotherapy or other approaches. So one of the things that was developed recently, this mycetos, it was done, our launch between different partners from Erasmus Medical School and DNDi. And this is a mycetoma open source project when you can find all the data about the discovery of new drugs that target the fungal type of mycetoma. Still, we are working with drug discovery. This is one of our PhD students. She is now validating 5 products under in vivo evaluation for treatment of mycetoma. So we should encourage such type of research that will lead to more favorable treatment for mycetoma. The diagnosis of mycetoma starts with a clinical examination by the doctor. Then we have to go for the imaging, MRI, X-ray, ultrasound. Then we have to do the culture, cytology, histology, molecular techniques. Most of these techniques are of low sensitivity, specificity, invasive, and very expensive. And most of the patients are poor, and they cannot afford this type of disease. That's why we need, and there is an urgent need for a simple, affordable point of care diagnostic test. Now what we are doing is trying to find or to develop a novel diagnostic PCR that can detect all mycetoma types in one single reaction. And also we should think that most of these patients live in the villages outside the main area or the center. Lastly, I want to share our experience with the rehabilitation care for the patient. This is what we call the Mycetoma Vocational and Entrepreneurship Training Center. It's called Said in Arabic. It means help or please help us. So this center is now located in the Mycetoma Research Center, and it helps the patient to rehabilitate and to become independent. And it's a training hub with different workshops that give the patient the opportunity to be trained and to go back to their communities after the disability and become more secure. So I'm just sharing this video about this hub. I hope it works.
تم إنشاء مركز مايستوما المهني للتدريب وريادة الأعمال ساعد بغرض تدريب ورعاية مرضى المايستوما الذين قد يتسبب المرض لهم في إعاقة أو يفقدون مصدر إعالتهم بسبب المرض، فيوفر المركز لهم التدريب والمهارات اللازمة لتعلم حرفة مفيدة تساعدهم على كسب عيشهم وعلى مواصلة حياتهم.
واحدة من المنتجات أو البرودكت اللي بدينا نشتغل عليها هي إنتاج الشنط بشكل عام والشنطة المدرسية بشكل خاص. وكان اختيار هذا المنتج لأغراض عديدة. الغرض الأساسي إنه يساعد مرضى المايستوما في المناطق اللي بيعانوا منها، ويكون دافع لعملية تقليل التسرب المدرسي في هذه المناطق، بالإضافة لأنه يمكن أن يتم تصنيعه بطريقة، لأنه في الماشينز أو الآلات الآن بتشتغل كهربائيا، فبعض المرضى الذين فقدوا رجلهم مثلا يمكن أن يتم تطويرهم وتدريبهم على أنهم ينتجوا هذه المنتجات. هذه فكرة اجتماعية تمت مع مركز المايستوما كمساهمة.
Yeah, so this part of our activities as side or the hub, and you can see most patients are rehabilitated there in this center. So as a conclusion for my presentation, so we are facing a lot of challenges as in neglected tropical disease, and specifically in mycetoma. There is a huge global gaps in knowledge about the disease. It's the most neglected disease, and patients, there is a lack of medical reporting systems. And as I said before, there are more than 70 causative species for this disease, and that cause a complex immune response in different disease phases. And this also will make it very difficult to create a vaccine for this disease. And lastly, the lack of sustainable funds for such a neglected disease. So this, I shared this campaign was done by the MRC the last month. Through this campaign, we did a lot of health awareness, a lot of interventions for the patients in the endemic area. Thank you.
Thank you very much, Dr. Bakheit, for your presentation on mycetoma. We're going to go into 10 minutes of Q&A, and I'll ask each of the panelists a question, and then I will invite you also to ask them a question if you have one. I'm going to start with you, Natalie, on your presentation on HAT or sleeping sickness. Well, for me, it's something that reminds me of my childhood. I grew up in a community where there was a lot of research, and there was the trypanosomiasis control program, and I remember their old Peugeot 504, which had the trypanosomiasis research or control program on it. Now we don't have any, or we like to think we don't have any in Ghana now. Nonetheless, it's clear it still remains a problem. How close do you think we are to completely eliminating HAT, where we will have 0 cases? If I were to push you to give a timeline based on what you have seen so far, and now perhaps this wonder drug, Cosiborol.
Thank you for the question, John. It's not simple. I think people say that the last mile is the most difficult mile, and we have to think about that. Let's not just say, I think we have tools, We don't have yet a diagnostic or a system that can be simpler. And you know the issues of the sensitivity of RDTs that decreases when the incident decreases. So I think quiet but solid vigilance on the fact that until it is really, we have proof that there is elimination of transmission, let's not lose focus on the very important need to continue to identify patients where they are and go to FOSI and continue to have funding to do the access programs. The good news is that because we first have fexinidazole, which is oral, which is most of the time not going to require patients to be hospitalized, there is more, I would say, reassurance from the communities that they could get a treatment that is not going to stigmatize them, that doesn't require them to go to hospital, to lose money, and for the many resources that they have to go to be treated. So there might be more adherence to treatment on one side, with more vigilance on detection on the other, and maybe with acosiberol we will overcome the fact that there might be less specificity of RDTs, and we can dream of a test and treat strategy in a FOSI where you have one case, then you treat the village. It is not yet possible, but maybe that will be. So, I think we're in a very good place, but we are only in a very good place if we continue to have training, understanding, community awareness and communication at the community level that, it's not over yet. So I want to be quite cautious there. But there is a lot of optimism because we have much better tools.
Thanks, Natalie. And a very quick follow-up one. What about in cattle and the animals? How much of a risk do you think this poses to success?
So rhodesiense clearly is transmitted through animals as well. So we have to be ultra careful. And I think TB rhodesiense is another very important threat that we're not finished with because there are also a lot of undetected cases. And there, one of the things that my colleagues from DNDi did with their partners was to promote the early identification of patients in areas where there might be a risk related to the bearing of the animals. So, yeah, that one is, I think we have to be careful on that one, more careful, because it travels.
Indeed.
With the cattle, yeah.
Indeed. Thank you very much, Natalie. I'll come to you, Dr. Ukati. And you gave us a good overview of ONCO and how far we've come. APOC was there for a long time and did a lot. And, well, no use crying over spilt milk, as they say. But I would like to know your thoughts regarding the move from, or the disbanding of APOC, and whether you think, I know it's a sensitive question, but I think we can indulge a bit, whether you think this was a drawback for ONCO, and well, if you think so, or otherwise, looking forward now, do you think that we are on track to meeting the targets that we've set in the NTD roadmap?
Thank you very much for the question. And as you said, it's a very difficult question to answer. Why? Because it's dealing with funding. I think OCP, 28 years, and later on EPOC, 20 years. I can say that it was a good thing in order to allow countries to try to own the programs, because without ownership, it's going to be very difficult to eliminate the disease. So it was a good thing to take that decision, and now we need to advocate a lot to the Ministry of Health, to the government, to own the programs. I know there are countries out there where we have a lot of money, and we have to advocate. We have to work very hard in order to generate domestic funding. Without that, I'm not sure that we are going to eliminate the disease. I don't know whether or not I've addressed your question.
No, indeed, thank you. And how close do you think we are to meeting the targets? Are we on track? Maybe a simple yes or no, although I know it's not that simple.
I think we have countries where things are going very well, and there are countries where really we have to invest a lot in developing human resources within the country. Without that, it's going to be very difficult. We need to build capacity within the country.
Thank you very much, Dr. Kati. I'm coming to you, Dr. Bakheit, and your presentation on mycetoma. You made it clear that this is so neglected. It's also a very dramatic disease, for which one would think surveillance should not be a problem because it's pretty much in your face. But for some of the pictures you showed, I wonder, for people who have already been deformed and with all these granulomatous lesions, is there hope for restoration, even to be able to be as mobile and perform their duties as normally with the current treatments that we have, the current interventions?
Yeah, thank you for this question. Actually, it's a very ugly disease, especially in young people. And what we were doing in the last 3 years, we were trying to help the patient to get an artificial prosthesis from different donors, companies, because most of these patients are really poor. So we have a mobile workshop. It goes directly to the villages and perform all these activities there in the villages and give artificial prosthesis to people there. And we have also some physiotherapists. They go with us. They train the patient to go back to their normal life. So we have now one of our students in the center who created this device, electronic device, as our artificial prosthesis that you can move it with your shoulder. So there are so many research going on this part of the disease because the disability is really a problem in mycetoma patients. As I show in my presentation, we have this vocational training center. We have a social workers, we have a psychological work done for this patient. So we are trying, but we cannot say that they will be like 100% back, but we are trying our best to help those patients. Thank you.
Thank you very much, Dr. Bakheit. Natalie?
No, yeah, I'd like to add something because I think, you know, the pharmacology of, the pathophysiology of mycetoma is very complex. Yeah. But as Doctor was saying, the strategy now is to do to give a treatment and then do surgery. And what we have seen in the study that you were mentioning is that when you treat early, you can make sure that the lesions sort of are encapsulated. You remove the lesion with surgery and you may reach cure. And in our study, we have quite impressive cure rates, around 60 to 70% with that strategy after 1 year treatment. So it is not ideal, but it's already huge because those patients will not be amputated, which is otherwise what's going to happen. So it is not enough, but it can, you know, it's already something. The second thing that this highlights, which is the same for many NTDs, is early diagnosis. And we do need to have also investments in early diagnosis because clearly when the lesion has almost eaten everything, including the bone, there's no hope that a medical treatment will do anything. So, yeah.
No, thank you very much for that. We are on time, but I'll invite just one question from, okay, I saw the hand first, the gentleman closest to the camera, and then we will have the next session. Hopefully, if there's time, we will come back to more questions. Yes, please.
Thank you very much. I am Timothy from Uganda, final year medical student. And the question goes to the panelists today. I want to ask if the effects of climate change have been considered in this fight against NTDs, because we know, especially for the vector-borne NTDs, there could be expansion in breeding zones. So have these effects been considered? Thank you.
All right. Because of time, I'm going to ask Dr. Uketi if you can answer this specifically, because, of course, we know the role that climate has to play with regard to river blindness.
Yes, thank you very much. And I think that's true. The climate change has an impact also on NTDs in general, and especially on the vectors. In case of onchocerciasis, which I know very well, we have found places where the vectors just disappeared due to the climate change, due to the environment changes.
Thank you very much. If you could kindly join me in a round of applause for our panelists for this first half. Thank you very much. You may kindly resume your seats. We're going to go on to the next half, and I believe it will be equally exciting. And to kickstart, we're going to have actually 4 presentations this time. I'm going to call all 4 up to seat in order from my far right. Simon Bolo, Dr. Nene Sala, Dr. Damaris Matoke Muhia, and Philip Frisch. A round of applause for our panelists. Now we're going to get into a little more regarding the access, the treatments. What's the point if you have these wonderful developments, but those who need it the most cannot get them? And Simon Bolo, who's head of the Leishmaniasis Access DNDi Kenya, is going to be speaking to us. I've known Simon for several years now, and I know he's really passionate about this work, particularly access, and he's come all the way after heading the operations portfolio at DNDi Africa. He's well experienced in how the mechanics of how activities really run. He joined DNDi all the way in 2005 and has been actively involved in the Leishmaniasis East Africa platform, otherwise known as the LEAP platform. He's trained in business as well, holding an MBA from Strathmore Business School at the Strathmore University. And so, Simon, if you could kindly give us some information on what it means to access some of the wonderful treatments that the earlier speakers spoke of.
Thank you very much, Dr. Mosi. And I'm really pleased to be here in front of this stage today, in front of eminent panelists. Actually, I would call myself an underdog coming here with a finance background, but in the presence of scientists. But I'm happy to say that with the mentorship of my boss, Dr. Wasuna, and the likes of my senior Professor Musa, who's seated right here, able to aptly pronounce Leishmaniasis, which is a very difficult name to pronounce. So today, I'm going to talk about access to Leishmaniasis treatment and specifically solutions Africans for Africa. Why? Because in the past 1 year or so, when I took over the leadership of the Access program, the experiences that we've had as DNDi in the field is showing the kind of challenges that you're faced with and what we need to do. The video or the film that was shown earlier did me quite a lot of justice by highlighting what Leishmaniasis is. But before I move forward, maybe just to explain that how I'm planning to make this presentation is first talk about the challenges that you're faced with, really the key challenges, then look at what is in the pipeline, and finally the proposed solutions from an African perspective. So just a quick highlight again. I think you by now you should know about the disease, but Leishmaniasis, like other NTDs, is a disease of poverty and inequity. If not treated, patients die. It has mainly three forms, that is visceral leishmaniasis, cutaneous leishmaniasis, and mucocutaneous leishmaniasis, but also has certain presentations linked to visceral leishmaniasis, that is post-Kala-Azar dermal leishmaniasis, which is a skin rash and is believed to be a reservoir for new infections, and as well as co-infection with HVVL, which is a very complicated complication, or rather presentation to treat. 68% of the global cases occur in our region, that is the Eastern African region, according to WHO, and we are seeing rapid rising incidence of the disease in the region in the last couple of years. We also have the CL that I talked about earlier is highly neglected, it is underreported, and with suboptimal treatment. Climate change obviously is a major a driver here that is introducing new endemic foci that we've been seeing, especially in a place like Kenya, and leading to possible outbreaks. We are faced with grave challenges as in the attempts to accelerate access to treatment for visceral leishmaniasis patients, and top of which, on the demand side of the access program, we are realizing that if we do not tackle these problems, then we are going to be faced with a very, very major catastrophic situation. So on the demand side, we are still faced with issues around poor diagnostic options. The RDTs that we're using are still not very sensitive. We have still poor health-seeking behaviors in the communities, and the policy change process takes quite a long time. For example, the current standard of care that we're using, which is SSG and PM, took almost 7 years for the patient to start accessing. And then these demand issues are actually affecting the supply side of the equation, where we still, despite having a few or rather better treatment, which still are not quite optimal, we have single manufacturers, and then procurement challenges that we are faced with, as well as product registration challenges. For example, the manufacturers that we have really need to be incentivized to be able to register the products that are coming in the pipeline. On the financing side, like everybody, like all the other NTDs, we are still dependent on donors, and then this actually, this year we were faced with a real problem, an acute problem of financing when the UK FCDO pulled out. They're the ones who've been financing procurement of commodities in our region. And this resulted in acute shortage of possible drugs. Up to now, we do not know where we are going to be able to finance drugs in from 2024 moving forward. Now, while we are faced with these challenges, we have in the pipeline a number of key issues that I would want to elaborate on. One is we are starting to have a discussion around the elimination strategy for VL in the Eastern African region. In January, the WHO is organizing a meeting in Nairobi where a plan or a strategy is going to be developed for the elimination program. At the same time, we have a new treatment that is miltefosine and paramomycin. The miltefosine is the first oral treatment that we're going to use for visceral leishmaniasis. This came out of a phase 3 study that was coordinated by Professor Musa and the likes of Dr. Monique. And we are talking about adoption, and we're trying to see on how to accelerate policy change and guideline change in the region so that patients can be able to have access to the new treatments. There's innovation in the pipeline. Monique talked about big things that are coming up in the film, and these include the new chemical entities that in the pipeline that DNDi is trying to develop, and you're hoping that this will be oral drugs that can be taken over a short duration compared to what we have right now in the market. And also we also have in the pipeline new antigen-based RDTs that are going to be developed and may revolutionize the platform and ensure that we have a proper test and treat strategies. Therefore, with all this in the pipeline, we need to prepare the landscape for the new product as well as the plant. Now, what needs to be done? Again, like I've said, based on the experience we've had in the field, we've come to realize that we as Africans must come together. We must take ownership of our problems so that we can be able to sort out the problem. Building sustainable ecosystems is very key, and here we need our governments to take ownership. This has been repeated in various forums this week. We need leadership from the government so that we can unlock domestic financing so as to deal with the problem that we are faced with right now. We need to move from donorship to ownership, as was said earlier in the day. We have the issues around regulatory harmonization. We are thinking that having a regional platform, for example, we have the African Medicines Agency that was set up. It needs to be strengthened and operationalized, as well as supporting the regional economic blocks so that we can be able to achieve regional regulatory frameworks. Collaboration is very key. True collaboration is needed. The Kigali Summit, which came up with the Kigali Declaration, highlighted very clearly that true partnership has shown that we can be able to eliminate or end the NTDs. So having cross-border collaboration, strengthening partnerships, for example, the LEAP platform that was mentioned in the film has been a good showcase of how partnership can be able to help alleviate the problem that you're faced with. We must rethink community involvement so that we have ownership at the community level and have community-led initiatives so that we can be able to have patients referred faster than is happening right now, and because this has been proven to achieve better treatment outcomes. We need strong policy engagement. We need to have a regional agenda with local impact. We are thinking, why not even have develop a regional treatment guideline rather than the national treatment guidelines that you're faced with. This way we are able to accelerate a guideline change so that we can have the patients accessing the medicines as fast as possible. Of course, we need to rethink capacity building, and then talking to somebody earlier, we were even saying it needs to be actually called capacity sharing rather than even capacity building. We need to think about local manufacturing, but we need to think about scale as well. We need to stop thinking about health as a cost center, but rather as an investment so that we can have more and more investment in this area. So to conclude, because I can see that my time is almost up, as envisaged in the Kigali Declaration and the NTD roadmap, these actions, some of these actions which I've talked about, will help achieve relieve suffering, decrease the health-related drivers of poverty, and improve the general well-being of our patients. But solutions alone are not enough. Like Dr. Guel said during the opening ceremony, these solutions must be transformed into products. Then and only then shall we solve the problems that you are faced with. Otherwise, this will just be another talk show. Thank you very much.
Thank you very much, Simon, for that inspiring presentation on access to treatments for leishmaniasis. We're going to go on to Dr. Nene Sala. And she's going to be speaking on the role of youth as catalysts for innovation in NTD elimination. Nene has over 15 years of experience in research, particularly around the area of genomics, including using genomic data to inform therapeutic development. She's been a consultant for the WHO and has lectured in health informatics at the UCL and the London School of Hygiene and Tropical Medicine, and also at the Wellcome Sanger Institute and the MRC Gambia. She supports development in Africa and Southeast Asia, and is actually the co-founder of Health for Science Gambia. She had a PhD in genomic epidemiology and population health from the University of Cambridge, and she also is a Lindahl Nobel Laureate Fellow and a McKinsey Next Generation Woman Leader. And Nene, the floor is yours.
I will be talking about the role of young people today and highlighting some of the work that young people have been doing to fight NTDs. As the largest demographic, young people are also at the largest risk of NTDs. They're also major caregivers in their society. Youth represent a key constituent in the community. We are major agents for change. We are creative. We have innovative thinking and talent that needs to be harnessed in order to achieve an NTD-free generation. Youth Combating NTDs is the first global youth movement that represents young people in the fight against NTDs. We were established in February of 2020 to support the work of Uniting to Combat NTDs with the aim of eliminating, preventing, and controlling NTDs. Our driving rationale is to raise the visibility of these diseases and secure concrete commitments from relevant stakeholders toward ending NTDs. In July, we were selected to join the inaugural WHO Youth Council, and through such positioning, we aim to raise awareness of NTDs, amplify the voices of young people, and ensure the inclusion of NTDs in the global health agenda. Thank you. We have a global presence, and with over 800 youth champions, we are contributing to empowering and strengthening the voices of young advocates and leaders, and providing them with resources to ensure that their voices are heard and that their work can be seen. I will tell you a little bit more about the work that some of our champions are doing for this movement. As an organization, we are engaged at a policy level with local, regional, and international bodies. We have lobbied for the recognition and inclusion of young people and their role in the 2030 NTD roadmap. We have also led youth consultations for the Kigali Declaration and ensuring that youth are recognized as key stakeholders. In collaboration with other youth organizations such as the South Africa Youth Forum, we have been advocating for NTDs. In response to cuts from UK foreign aid, we have embarked on engagement missions with British High Commissions in 6 countries. We are also profiling NTDs at high-level events such as COP27, the Commonwealth Youth Forum, and we're collaborating with organizations to curate content and webinars on NTDs that address the role of young people in this fight. As a result of the COVID pandemic, we have been leveraging technology and innovation and resorted to online campaigns to continue our advocacy efforts. Last year, we launched the first global youth storytelling competition and NTD Youth Festival. This platform received a high number of very high quality entries from young people all over the world. And I was truly impressed by the creative ways they chose to share their stories on NTDs, from poetry to audios to visuals, not only raising awareness about NTDs, but also demanding that action are taken against these diseases. This had a huge reach with over 900,000 people, with our finalists being showcased on BBC, on local newspapers, on radio stations. And this really reiterates the importance of harnessing the creativity and innovation of young people and using their collective voices in this fight. Also, this is available online as a virtual gallery. You should really go and see it. It's fascinating. So I now want to just showcase the innovative strategies some of our youth champions are doing. Maria Teresa from Tanzania has developed an internet-free mobile technology that is really breaking down barriers in language, addressing digital health information gap, and promoting preventive health, and covers a wide range of NTDs through her platform. So she provides basic health information and education in local languages and has actually launched this in Swahili. This is really essential to increase the accessibility, and we know that for NTDs, a lot of the language can be pretty difficult. So breaking down this barrier will really increase access to information. Roland Elondu is a PhD student from Cameroon, and he is working on research that really matters to him and his community, and that is schistosomiasis in individuals living in endemic areas. Through this, he's also developing a mobile application using fancy modeling methods, which I won't go into because I don't really know too much about it, but he is addressing gaps in diagnosis. Atherton from Zimbabwe has launched a startup company called Hutano Diagnostics. And I remember, I think it was Dr. Sahar who mentioned that there are gaps in point-of-care tests. And this solution is trying to address that gap. It's developed to diagnose and manage NTDs, and particularly looking at early identification in children. This will provide real-time results to guide decision-making for treatment and prediction of severe outcomes. The really fascinating thing about these solutions are that they are homegrown. And in this new public health order where we're trying to shift from Western dependencies, this is a huge value add because these homegrown solutions will really help us achieve our health security and perhaps even ensure that communities, our own communities, readily accept them as well. So before I conclude, I just want to tell you a little bit about how we want to achieve long-term impact. And we envision that we will be doing this in 3 ways. We're already doing it, but we'll continue it in 3 interconnected outcome pathways. So the first would be by upskilling and empowering young people to advocate and ensuring that NTDs and lived experience are at the core of our strategy. Secondly, we need to continue to drive impactful partnerships, and not only with organizations, but within local youth networks as well. Thirdly, mobilizing resources. This is fundamental, as we know that NTDs are really underfunded. So we hope that we can hold our leaders accountable and put pressure on them to secure the right commitments that are needed, and also leverage technology and innovation to be able to achieve consensus and evidence-based decision-making. And to conclude, I just want to say that with a minimal budget and under 3 years of being established, we have had a wide reach and a huge impact. For platforms such as Youth Combating NTDs to exist and thrive, we need funding. We need partnerships. Imagine how much more we could do if we did have that. So I would like to encourage and invite stakeholders to support initiatives that are led for young people, by young people, like Youth Combating NTDs. I would like to invite you to support us. And I call on other stakeholders to commit to the Kigali Declaration and ensure that the right commitments are secured for our future. Thank you.
Thank you very much for that presentation, Nene, on the role that youth are playing. Really, really exciting. There'll be questions coming your way soon as well. We're slightly behind time, but we move on to Dr. Damaris Matoke Muhia from the Kenya Medical Research Institute. And she is going to speak on the impact of climate change on vector-borne diseases, which is one of the questions that was raised. Dr. Damaris is a molecular biology research scientist, and she's actually the acting Deputy Director for Biotechnology Research for the Biotechnology Research Program at KEMRI. Her work has focused on utilizing genomics in the control of diseases. And she has received a number of local and international research funding awards and recognition for her extensive work, and she supervised many PhDs and master's students as well. And also, she's big on mentorship, particularly young women in STEM. Dr. Damaris, the floor is yours.
Thank you. I'm going to speak briefly about the impact of climate change on vector-borne diseases, but immediately after I talk, I was thinking maybe I should have spoken about women, the role of women in the fight against vector-borne diseases, to just add to the voice what the youth are doing, because that's something I'm passionate about, and that's what I'm doing. So I think malaria and other neglected vector-borne diseases, most of them are part of the agenda of Sustainable Goal number 3, which talks about well-being and good health and well-being. And we are targeted to bring this to elimination by the year 2030. So what are vector-borne diseases? I just brought this here especially for those who have not worked on vector-borne diseases. These are diseases which are transmitted by a bite of an insect from human or from animals. And this, the insect could have had the infection. It has the parasite that causes the disease. We know that nearly half of the world's population is at risk or is affected by vector-borne diseases, which results to high morbidity and mortality. So based on the Global Vector-Borne Disease Control Response, which of 2017 to 2030, the vision is mainly on a world free of human suffering from vector-borne diseases, and it aims at reducing the threat from vector-borne diseases through effective, locally adapted, sustainable vector control. So as I mentioned, 80% of the world population is at risk, so it's not something that we can ignore. And the burden of 17% globally is being caused by vector-borne diseases. So from this map, you can see that Africa is brown. So most of these diseases, vector-borne diseases, are prevalent in Africa. And morbidity, people dying from the disease, is mainly from Africa, and also other underdeveloped countries. So based on the WHO map, we have about 17 of these diseases, and the ones that are starred on this table are known to be neglected. And most of them have been spoken about by the previous speakers, and they are endemic, as I said, in the African continent. So how this transmitted, we have both ways. We have the zoonotic, and also we have anthropogenic, whereby a disease is transmitted by a vector. A vector has to play a role in the middle. It can be transmitted from an animal to human, or it can via that bite, or it can be from human to human via vector. So why are we talking about climate? Climate plays a major role in the transmission of vectors. Why? You find that when there's change in the weather, or there's change in rainfall patterns, or when there's change in temperature, some of the diseases caused by vectors tend to disappear, to spread from places where they are to newer places, or they tend to disappear. They are removed, and so they wait. There's a season that they can appear again. So you find that there is seasonality of these diseases, and this is based on space and time. Human activities play a major role. So you find that people encroaching areas where the vectors are, or people trying to come to places in a way of migrating from places where they are comfort to places where these diseases or vector-borne diseases, vectors that cause these diseases tend to influence how far or how infections is done during the period. So this is a map. I picked this online. You find that climate change plays a major role. So it can affect both the natural environment or the social environment, where you find when there is rising temperature or there is heavy rainfall or flooding, the pathogen or the vector increases in number, and therefore affecting either transmission from the animals or transmission from human. So where you find there is vegetation cover, either vegetation disappears or appears, or there is the land type change, or there is change in the way the people are staying, whereby if there is a lot of rainfall, people tend to congregate together, or if there is no, the temperatures are high, people tend to go to places for shelter. So it's been documented that when there's change in climate, it makes distribution or infections from vector-borne diseases increase. Amongst this is temperature increase. If you look at the table there, the graph, it shows that yes, there are many others: rainfall, floods, drought, storms, land cover change, the oceanic climate, there is fires, heat waves, sea levels rise, but temperature is the main. When temperature increases, these vectors either increase in number or they tend to bite more. Then of those many other diseases, vector-borne is the leading, which is being attributed to a change in climate. So I'd like to list a few of the NTDs which are affected by change in climate. We have LF, which was mentioned before. This is lymphatic filariasis, which is transmitted by a bite of Anopheles mosquito. And this is when temperature increases, you find that the mosquitoes tend to bite more because there's increased metabolic rate. And this causes that this vector, apart from biting more, it moves from one geographical area to another because of warming global temperatures. When we talk about trachoma, you find that this is affected because of the flooding or drought, and this affects the strategies that is in place, which is known as WASH. WASH is the water, sanitation, and hygiene. So you find that either people lack water for washing, or people are not able to access clean water. So diseases such as trachoma and cystic cocconiosis, sorry for that, are the most, they tend to become more, and this can be both because of the dry spell or because of flooding. Then the other one is snake bite. It's also one of the diseases as part of documented by WHO to be a threat, and this has been seen in parts of the country where I come from and other parts in Africa. You find that snakes, as temperature increases, they tend to move from the metabolic rates increase, so they tend to look for either animals or people to bite, but also you find that they go to places where humans are, and also as they look for prey. So you find that there is more biting during those seasons when temperatures increase. Diseases such as schistosomiasis is also affected by increase in temperatures because it allows snails to be able to live further from the equator. They go to places where it's slightly cooler when temperatures increase. Leishmaniasis is one of them. This is a disease that is transmitted by a bite of sandfly. So you find that sandflies, as temperatures increase, they tend to move from higher altitude areas to lower altitude. So as part of some of the work that we've done, we were able to document that, yes, change in temperature and rainfall, precipitation levels caused a shift in vectors that transmit malaria. Because if you can see here, for a period of 5 years from 2011 to 2015, in an area where we had what we call as Anopheles arabiensis, which is not to cause malaria in Western Kenya, was removed, was eliminated, not eliminated, densities reduced over time, and we had to have Anopheles gambi, which was lesser, which was not in abundance during that period of time, increasing in number. For leishmaniasis, we've been able in Kenya, we've seen cases emerging from areas where they were not. We have visceral leishmaniasis, places where the disease was not, by having other sites coming up, like Kajiado, Kenya, which didn't have leishmania before, or having sites where the disease had been declared to be reduced or controlled coming up over the years. So, and this, and also we were able to document that there's coexistence of diseases whereby initially we could have visceral leishmaniasis alone in an area, but over time now we are seeing having both cutaneous and visceral leishmaniasis in the same locality. And this being transmitted by different vectors, so we are wondering what's happening. Are vectors also trying to move to areas where they could not adopt before? What's happening with global change? So in conclusion, I'm rushing because I've been told time is up. So in conclusion, I'm saying that yes, climate affects vector distribution, and this is in space and time. And amongst the factors that we've seen with change in climate is that the vector population size increases, or densities increases or reduces depending on the change of climate that time, or it increases or affects survival rates of the vectors, but also it increases or affects the number of these vectors that can transmit either zoonotic or pathogens that affect human to human. So what we are recommending is that we need interventions or innovations that also look into climate change or change in the weather patterns or environmental conditions when we are targeting to control vector-borne diseases. Thank you.
Thank you very much, Dr. Damaris, for that presentation, really highlighting the role that climate change has to play in the transmission of vector-borne diseases in particular. We're going to go on to our last presentation, and Philipp Frisch, who's with MSF Germany, is going to pitch to us as to why NOMA must be added to the list of NTDs. Unfortunately, I don't think we're the ones who make that decision, but maybe we'll join his bandwagon and wave the NOMA placard until it is included. So, Philipp, please convince us.
Thank you very much. So the good thing about being the last speaker after a very long day is that only the most hardened NTD aficionados are still in the room. So I consider myself to be among friends now, and we can talk about NOMA, which I think is high time. Thank you also for DNDi for inviting me on this very distinguished panel, and it was very interesting to listen to all of the other speakers before. So just in the sense of setting the scenes, I mean, we have heard about neglect already quite a bit today from different speakers here, but also in other sessions. And I think that this is not like a 1-0 kind of situation, right? So there's like a continuum of how much neglected a specific population is, a group of people is, and how much it is not featuring into a response, public health response, or any other kind of health response. And I think if you want to, if we have to basically draw a textbook example of neglect, NOMA would be a prime contestant for this title of being very much among the most neglected diseases, and the people affected by NOMA among the most neglected populations, which is not a coincidence. So the global inequity in access to healthcare, the global inequity of how much money is poured into research, into response, is also showing here. And NOMA is a very good example for this. So what is NOMA? I think I'm the only one without a PhD and not a medical person on that panel, so forgive me, I'm not going too much into detail. But the thing that you have to know about NOMA is that it's a necrotizing disease that is affecting mainly children from the poorest communities. It starts in the mouth and quickly leads to disfigurement and stigmatization. And the data we have suggests that we have a mortality of up to 90% if left untreated. And I think that this is also one of the common threats that we see in many NTDs, that actually the stigma is there as well, and it's basically also very interlinked with everything else that defines a disease like that. The good thing is, or the good news is, it's actually preventable and is treatable. So we can do something about it. With early diagnosis, it is manageable, and it's actually, even with the tools we have today, it is something that we can actually work on. So I'm here today to actually make only one prime call, and that is to get NOMA out of the shadows, to shift the attention and the limelight on that neglected disease. And a part of that could be to also call on the WHO to include NOMA on the list of the neglected tropical diseases. And I'm telling you, and I think that earlier we heard it from Dr. Amouazi, the two aspects of action, right? So we have to act, and we have to act now. And I'm trying to make the case now why we have to act on NOMA and why we have to act now. So first to the why. As I said, it is preventable and it's treatable. So if cases are detected early, actually, coming back to also the question of diagnosis, it can be treated easily with a short course of antibiotics and wound dressing. The other thing is that we can also influence the risk factors that make people vulnerable to actually getting NOMA. That is nutrition, it is oral hygiene, it is access to water, sanitation, hygiene that we also heard earlier. Again, the interlinkages of neglect, of economic neglect, of political neglect, and then also of health neglect. So we can do something about it, and we can do something with the tools that we have at hand already today. The second big question is, why act now? And I'd say, and I'd argue, and that came also up again already at the panel, is we have no time to lose, because the people that are, and the communities that are affected by these kind of disease don't have the luxury of time of waiting for something to happen. So we as a global public health community, I think, are very much under pressure to speed up these kind of processes, to bring resources and attention to people that are otherwise neglected. And especially with NOMA, the question of when you're actually starting to be active at a patient makes a huge difference. If the earlier you actually start your treatment, the earlier you are able to prevent the scars on the soul of people, but also the scars that are visible in their faces, the bigger your chances are that these kind of lesions and wounds are not that visible, are reversible. Oh, 5 minutes, okay, thank you. So the other thing is why we have to act now is we have real momentum now. So the government of Nigeria, together with civil society partners, like for example also MSF, but also DNDi, in collaboration with a broad coalition really, has basically compiled a dossier that should demonstrate, or is intended to demonstrate, why especially NOMA is meeting all the criteria that the WHO has for inclusion of a disease onto that NTD list. And this is, I mean, there has been a lot of debate around that. It's probably not like a golden bullet and everything will be solved by then, but it's one way and one function of actually shedding limelight on a specific disease, of getting more attention also globally in the research community, in the public health community, and trying to shift the attention really towards a disease like that. And it's something that we have already quite a lot of support, and the government of Nigeria has received a lot of supporting letters from other governments in Africa, but also in other WHO regions that are really arguing towards the WHO that this should be included into that list. So there's also a coalition forming among governments. And I mean, I will have a call to action later, but already now, if there's still people working in ministries of health in the room, and if you know that your ministry hasn't done so already, you might want to inquire internally if there would be a possibility to send a letter to support the Nigerian government's efforts to actually have this list, this disease listed as an NTD. I forgot about my slides. So, NOMA on the NTD list. And already, because I already started with it, maybe I just finish with the real call to action. So there is a lot of people working on this, and especially important, I think, are organizations like Elysium, that is founded by NOMA survivors, that actually go and be advocates for this specific disease, which takes an amount of courage that I'm hardly able to really understand, but they are really doing amazing work, talking about this in different conferences, trying to also put pressure on global public health actors to be more attentive and more focused on a disease like NOMA. So if you can check out this organization, also others, you find them on social media, amplify their voices, try to argue alongside them to have an inclusion of NOMA on the NTD list. Again, if you're working for an MOH, you know what to do. Find out if your Minister of Health has already sent that letter. If not, try to convince him or her to actually do so. And if you're an advocate working in civil society, working in any kind of organization, try to keep that in different dimensions of neglect in mind, and try to also push anyone, any global health actor, may it be on funding, on research and development, to have a stronger focus on a disease like NOMA, because I think that this is also one of those cases where we can really show how we as a global health community are capable of overcoming some of the inequities that are underlying diseases like NOMA, and how we can actually break the stigma and this neglect. Thank you very much.
Wonderful. Thank you very much, Philippe. Clearly a strong case being made for NOMA. In the interest of time, I will shelve my questions and go straight to you in the audience. And I'm going to ask specifically if anyone has a burning question for Simon, directed specifically at Simon. Prof. Ogutu, please go ahead. You can raise your hand so the lady, the microphone. Very well. Excellent.
Thank you very much. This is Dr. Gudu from Kenya. This note to Simon. I think possibly it is intriguing. I think is being a pediatrician when I heard of NOMA. And I think what I would want before I advocate for NOMA to join the NTD list, I would want to know what Nigeria is doing. Africa needs to own up. What has Nigeria done before they look at the globe to help them fight NOMA? I think, to me, I would want to see where are we.
Well, thank you very much. I think it's some more of a rhetorical question, right? In the sense that, of course, there's no one from Nigeria here to answer, of course, but really the need for countries to take ownership. And I think even Simon, in his presentation, the conclusion, did make mention of the need for Africa to take ownership, really, and responsibility for the problems that plague us. So I think it's really important that in this fight, we try and be very clear with what the governments themselves are doing to address their own problems. So thank you very much for that comment, Dr. Ogutu, and maybe, Philippe, you can address that if we have the chance when it gets to your turn. But Prof. Musa, you had a question for Simon? A comment, yes, please go ahead. And then the hand over there afterwards.
Thank you very much, Mr. Chair. Professor Musa from Sudan. I'd like to add my voice to Dr. Ogutu from Kenya that NOMA should be included in the list of the neglected tropical diseases. NOMA complicates leishmaniasis, visceral leishmaniasis, and we have seen many cases in that. And I have seen reports on HIV NOMA in a child. Thank you very much.
Thank you very much for that. I think it's also very strong to highlight these co-infections as evidence of the need to advance this. I will let you go, although I saw a hand first, but your hand was up during the first session, so please go ahead.
All right, thank you so much. I'm Susan Okwakol. I'm from Uganda. I'm a midwife by profession. My question goes to the panelists, the first panelists, and then now the second. Since we are connecting from identification and we've gone to treatment, I wanted to understand and know, since you want these diseases to be included, or there are already those that have been included, what strategies have we made as countries to actually look at the perspective of public health at the grassroots level? Because if we want to include, can I, a community member, be informed about NOMA? Can I be informed about less that, you know, I might bite my tongue. So how can I be informed about that such that a person in the community can understand these are the signs and symptoms of these neglected diseases? So as nations, as African nations, can we start by educating the communities such that they know that these are diseases that are existing? They are not neglected as such, but they are existing. We only need to inform the community of all these diseases. Thank you.
Thank you very much. I would like to ask you, Simon, to just give a 30-second response to that, and Nene as well, if you could respond to that, given you did make mention of one innovation of a young innovator in Tanzania. So Simon, 30 seconds, and the same for you, Nene.
Thank you very much for that question. What we're trying to do, and what I actually mentioned in my presentation, is that we are trying to strengthen the communities by training the CHVs, creating awareness in the communities so that they can be able to refer patients at the earliest possible time. We've seen this happening in the northern part of Uganda, Amudat, where we were even last week, in Kachaliba in Kenya, where we've seen an increased number of patients seeking treatment after engaging in community awareness sessions and training community health workers. So we need a concerted effort to continue with this strategy so that communities can take ownership and leadership in the process. Thank you.
Thank you, Simon. Nene?
Yeah, so I mentioned it's really vital to harness the innovation of young people. So we have a young innovator from Tanzania who's developed a mobile application using internet-free technology that translates this health information. So also finds translation for the names of these NTDs, which are a mouthful sometimes, into languages like Swahili. And this really breaks down barriers in access and increases accessibility to this information. And you're right, this is very vital so that the communities themselves can identify and know how to prevent these diseases as well.
Thank you very much for that, Nene. We'll take another question. Yeah.
So good evening, I'm Caroline, just like to stand. Maybe Simon, you've probably answered the question, because I was just going to ask the question that, I liked when Natalie spoke earlier. What specific steps are we taking to address this issue of early diagnosis? I served as a county first lady for Bungoma County in Kenya, and I was introduced to the issue of neglected tropical diseases by the End Fund. And honestly, I was shocked because in all my years in that county, these diseases have been there, but they were almost invisible to my eye. And I consider myself a well-educated person, somebody who cares for what's happening. How do we reduce the invisibility of these diseases? I used to grow up seeing people with elephantiasis, and I thought they're born like that. I never thought that, it's caused by a vector bite. And there is such a strong iniquity to these diseases that really just tugs at my heart, that it's always the poorest. Dr. Matendechero always says NTDs start where the road ends. I just want to understand, I know you've done a lot, and I know I'm coming into this topic of NTD very late, but I just want to ask, how far have we gone to try and access the areas beyond the road to try and reach these people? And I was going to ask the question about what kind of campaigns are you doing? Because there are two places where you have a gap. It's either the community like myself who are hugely ignorant, very educated in so many spaces, but hugely ignorant, who are watching people suffering with these diseases, who are doing nothing about it. But also, I can tell you, it's also the healthcare workers, because I got an opportunity to interact with healthcare workers in so many of these places. And diseases like sickle cell disease, which are endemic to our place, were even healthcare workers were not aware of them. So at the point at which somebody is coming into a health facility for the first time presenting with symptoms, to what extent is that healthcare worker able to, at least give the right direction to this particular person? And I'm a big believer in the community strategy, so I'm glad you talked about the CHVs, because I was going to say, use those people. They know exactly what's happening in every house. They know exactly what kind of things are going on there, and they can be a great help. And to everyone here, I just love to say, I would love to help with NTDs. If you think my voice can be of importance anywhere, I know how to shout. Can be in the village, can be on a huge platform globally, wherever it is. Just use me, because this is something we can do something about, and I really believe that it's time we stop neglecting them, and we took some action. And thank you for the great work you're all doing.
Wow, that's so inspiring. So, Simon, I don't know if you want to comment on that very quickly, although it's quite long, and then I'd like to have a question also directly to Dr. Damaris, and then to Philip. If there's no question, I have questions pending for them. And by the way, your question was one of those I had.
So thank you very much for that. A very quick answer to that is we are using a multi-pronged approach. So we are starting with the communities that are affected. We are creating awareness so that the suspicion index of the community is higher, so that they can be able to refer patients as fast as possible. And like I said, this has been proven to improve the treatment outcomes. We are using the community leaders. We are talking to them. Like last week, we are in the communities where we are disseminating the results of the study that I talked about, and the community leaders were involved, and they are able to see what is happening and talk about the problem that you're faced with in the community. At a national level, we have the likes of our communications team here, led by Lynette, who are discussing with the policymakers to ensure that we also, the policymakers are aware about this. We have, you saw Luke Kanyangareng is somebody I personally know. He comes from Kacheliba Hospital. During the community engagement in Amudat, we took him across the border, and he was able to inspire the rest of the patients so that they can come out, get treated, and hopefully get a better life. So,
thank you.
In short, that's what we're doing.
No, thank you very much, Simon. And the refreshments are at the back, and I think they have started serving in fairness. Just indulge me, let me allow us to hear Dr. Damaris' voice, and then Philip as well. Damaris, this triangulation of NTDs, climate change, and then One Health, what are your thoughts on this, given that a lot of these vectors really have intermediaries that involve animals, and some of these animals themselves are vectors anyway in themselves. So just your thoughts on that.
Yeah, thanks for that good question. I think one of the things that we need to admit is that there is no way we can work on human health diseases, ignore the effect of animal health, and also ignore the fact that environment. So my thoughts are that we need to think what are the strategies to control infections to animals, but the same infections that come to humans, those are the zoonotics. So the One Health concept is important, especially in the fight against NTDs, and needs to be strengthened to bring all stakeholders on board, the entomologists, the parasitologists, the molecular biologists, and also the meteorologicals in this. Yeah.
Thank you very much for that, Damaris. And finally, Philip, as I conclude, you're trying to get Norma onto the list, and Dr. Gutu and Prof. Ahmed have already commented on this. Can you share with us anything you know about what Nigeria is doing specifically? And then also, getting an NTD onto a disease onto the list is really politics, to say the least. Sometimes a bit nasty. How ready are you for the fight?
Share with you. Yes, thank you. Sorry, just already not even able to get the microphone working. Okay, a couple of things. I think also one of the questions in the room was well, there's more than one factor to a successful health intervention, right? And I think it's absolutely true. You need information, you need a program. If you have the most brilliant program and the most brilliant drugs and no one knows about it, you fall short, right? And the other way around as well. So I think we need all of that. And the reason why we are also focusing on NOMA so much at this point is that if a disease is so much in the shadows and not even assessed what is missing, and it's not even featuring in many of those discussions, then where are we even starting, right? So I think that it is one attempt to increase the attention. It's maybe not the most brilliant one, but it is one attempt to really get more attention to a disease that is otherwise falling through the cracks, also of attention, even on forums like here, right? So this is maybe the one thing I want to say to that. And the other thing is also, I don't know who said it, but the entities start where the road ends. I think this is, again, speaking to this very particular additional factors where you have to be more holistically in looking at a disease like that is born so much out of poverty and out of being neglected not only in terms of health but also in terms of economics, in terms of access to water, in terms of all of these things that are working together, and to have a more holistic way of looking at these kind of patterns is probably one of the first things that we have to do.
Thank you very much, Philippe. I'd like us to give a round of applause to our panelists. And if you can just remain seated while I invite the director for the DNDi Africa Regional Office. I may introduce you as the indefatigable Dr. Monique Wasuna. A round of applause as she comes to give us a closing remarks, and then we can access the refreshments.
It's been a long day, and you are the faithful. I really, really appreciate John. I call him my son, my firstborn. So John really led the team, and thanks to all of you and the ones that went down. Thank you very much for these excellent presentations. I think you agree with me that we were tired, but it was exciting. I didn't see anybody falling asleep. So let's give the chair and the panelists really a loud clap, And I'd also like to acknowledge you, the audience. Really, you are, asking questions, and you're very animated. And that's the spirit. We need that spirit to be able to overcome. And I think that, Philippe, you need this spirit for us to really fight with our governments and ask, go knock on their doors. Have you committed to into putting NOMA in the list of NTDs? I was in a meeting, in an African meeting, where many governments have actually written letters. So I think that find out if your government has not written a letter in support, this is the time to act, and we must act now, right? So thank you for that. We support NOMA to be, how many people support NOMA to be on the list of NTDs? You see, all of us. In fact, you should take a picture, and we have our hands, and then it's away. Yeah, so thank you very much. So thank you, the audience. A big clap for you again, really. And Mrs. Wangamati, you are full of energy. You are on board with the NTDs. So you're welcome to join the team and, do what you do best. So thank you. I'm standing between you and some nice drinks, some food. So I would like to leave it there. On behalf of DNDi, really thank you. And I thank my own team. They've been working for months on this. So Lynette and the team, thank you very much. So thank you. I don't want to say so much. Have a good day, and thank you very much.